or what else? And lid wiper epitheliopathy and dry eye is a symptom of each other. I mean that when patient have dry eye and patient also have a lid wiper epitheliopathy or not. Or is there any patient who have only lid wiper epitheliopathy and no dry eye or not? Yeah.
I understand the question.
Yeah.
This condition is not a criteria for diagnosing dry eye.
Yeah.
Yeah, and but the importance of diagnosing this condition is it can imply the pathophysiology of the dry eye, because there are relationship between this condition and the aqueous deficient type dry eye. And another proposed etiology of this condition is the decreased wettability of the corneal surface. So when you see this condition in a dry eye patient, you can have in your mind what is the reason of this dry eye. And not all dry eye patients have lid wiper epitheliopathy. I've never seen a patient with lid wiper only and no symptoms. Because usually when patients come to us, they always have complaint or symptoms. Yeah. And no symptom patient, we never saw that.
No.
We never see that patient.
So the patient have a lid wiper epitheliopathy, sure. And the patient have a symptom and also have a sign, but that's easy. But my question is it related to any other disease? For example, related to dry eye or related to contact lens wearing or not? And,
yes.
And it always associated with other disease, or it can exist alone, itself. Yes. You understand what I mean? Yeah.
What I read, according to what I read, they said that it's a condition that can stand alone.
Yeah.
And
I got the professional questions. I think the lid wiper epitheliopathy is not a real disease, but it is maybe seems like a consequence of the abnormal frictions between the eyelid and the ocular surface. For example, in the patient with dry eyes, lubrication is not enough. So when the patient blinks, so the friction between the eyelid and ocular surface to cause it dizzy. And some patients who wear contact lens or contact lens, so the ocular surface become harder. So the friction between the eyelids and ocular surface cause the lid wiper epitheliopathy, I think.
I think so, because this one kind of let's say that conjunctival pathology, but it's not true conjunctival because there's a conjunction between mucosas and skin structure. So it's between two areas, or let's say that a transition area between skin and also mucosa. And usually we didn't pay much attention about this area, so we didn't recognize or we overlook the disease. But when we see the sign of this disease, it means that I think there's some patient may have dry eye, or patient may have increasing friction power. It means that the contact between eyelid and the ocular surface increase, and the contact between two structures makes a change in such area. So, is there any question?
I think the lid wiper epitheliopathy will cause the dry eye become worse.
Yeah.
because the midwifer have a responsible for the maybe for the spread tear film when the eye film.
Yeah.
So if there is the midwifer enteropathy, will make the spreading the become abnormal. So
Yeah. But we don't know dry eye cause least wiper epitheliopathy or least wiper neuropathy cause dry eye. We don't know. We cannot say
which
which
is
one.
the pathologic cycle.
Yeah.
Yeah.
Yeah. So, is there any comment or questions? I just would like to have a comment about presentation. If I was you, I will present this one in English. I will present this topic in Vietnamese. For example, I will give presentation on Friday symposium, not today, because it's a new thing, a new pathology, and usually we overlook the disease. That's one reason, and the second reason for the terminology. It's quite difficult for some doctor here to understand the presentation and to understand the pathology. So if you present in Vietnamese, I'm sure that people can understand more and can learn more about the new thing, the new pathology. It's new to us, but not new for the ophthalmology in the world, because people know it quite a long time. Yeah.
In fact, until now, it hasn't named the midwifer into Vietnamese.
Yeah. Yes, because it's new, so we didn't have an appropriate word to translate it into Vietnamese. But for the name of the disease, we can use English name. But all the sign, the symptom, and the mechanism, and the treatment, we can have Vietnamese to talk.
Yes.
I think we have enough vocabulary in Vietnamese. Yeah, that's my personal comment about that. So the most important that the audience can understand what we want to say and what we want to talk today. That's more important. But anyway, we have learned about the new pathology, and it's usually overlooked by the ophthalmologist. And now we can, when we see the patient with a contact lens, or we can see the patient with dry eye, and we can see the ocular surface disease, we remember to see on the eyelid area, and we recognize and we use a examine green to check, to stain the conjunctiva, and to see if the patient have a lead wiper epitheliopathy or not. Thank you very much, Dr. Han, for your presentation. And now we move on to the second one, the second presentation, and this is the Association of Cataract Surgery and Risk of Diabetic Retinopathy. And I'd like to invite Dr. Ramji Thoa to talk, please.
Good afternoon, everyone. Dear Professor Wilson, dear Professor Pamadon, dear teacher, and everyone in the hall today. My name is Thoa. I'm president. Today I'm honored to be here to present a study with subject Association of Cataract Surgery with risk of diabetic retinopathy. As we know, cataract and diabetic retinopathy are the leading cause of acquired blindness worldwide, and patients with diabetes have an increased risk of developing cataract. Although extraction were the standard treatment option for cataract, but it's also reported to occurrence and worsen diabetic retinopathy. It can be lead to breakdown of blood-retinal barrier, breakdown of blood aqueous barrier, and intraocular inflammatory response. For this reason, the current diabetic retinopathy care guideline makes some measure for preoperative stabilization, includes optimizing glycemic control and perform pan-retinal photocoagulation to prevent complication post-surgery such as neovascularization or visual hemorrhage. But nevertheless, cataract surgery and the risk of diabetic retinopathy still not well understood, and some previous studies were of short follow-up periods of 6 to 12 months, and there are limited reports in this area. Especially for long-term follow-up and in Asian population. Therefore, this author performed this study to assess the risk of developing diabetic retinopathy after cataract surgery amongst individuals with type 2 diabetes. The study besides this is a population-based prospective cohort study, and the baseline visits were conducted between 2004 and 2009, and a 6-year follow-up from 2011 to 2016, and a statistical analysis were performed in 2019. And participants were recruited from the Singapore Malaysia Eye Study CIMES and the Singapore India Eye Study CIMI. In 6,680 participants from CIMES and CD study, there were 2,372 participants with diabetes, and among these patients, there were 1,844 participants without diabetic retinopathy, and in last analysis, 972 participants on 1,734 eye include. The result, this table shows the baseline characteristic of participants with diabetes with or without insulin diabetic retinopathy. As baseline, participants who develop diabetic retinopathy mostly male, higher risk of current smoking and anti-diabetic medication, higher mean HbA1c level, and a longer duration of diabetes and a lower mean BMI. There were total 350 eye undergone cataract surgery, includes 163 eye as baseline and 187 eye any time during the follow-up periods. Among this eye, there were 77 eye developed diabetic retinopathy, hold 22%. In the other hand, 1,384 eye never underwent cataract surgery. There was 195 eye developed diabetic retinopathy, hold 14%. These are the observed association between baseline cataract surgery and diabetic retinopathy incidence. The results show cataract surgery as baseline were associated with more 2 times greater risk of developing diabetic retinopathy. And these are also observed the association between cataract surgery performed during follow-up periods and diabetic retinopathy incidence amongst baseline phakic eye. And eye which underwent cataract surgery at any time during the follow-up periods will also more likely to develop diabetic retinopathy compared with eye that never underwent cataract surgery. And this table shows the association between any prior cataract surgery and diabetic retinopathy incidence. And the results show any prior cataract surgery were associated with increased risk of diabetic retinopathy. For conclusion, prior cataract surgery were associated with a higher risk of developing diabetic retinopathy among individuals with diabetes. This risk were observed mainly in incident mild and moderate diabetic retinopathy cases, and it's maybe considered lab for patients with diabetes to be recommended for more frequent diabetic retinopathy screening after cataract surgery. Thank you for listening. I'm looking forward to receiving a comment and expert for the expert on this topic. Thank you very much.
Yeah, thank you, Dr. Thua. Yes. So another topic relating to cataract and diabetic retinopathy. And from the study, it concludes us that after cataract surgery, the patient have more risk of having diabetic retinopathy. So we have to pay more attention about that. So is there any question or comment from the doctor? Yes, doctor. Dr. Dad, do you have any comment about that? I'm sure you did many cataract surgery on the diabetic patients. So what about your experience?
Thank you for your presentation. I think that's the news. The result is not new for us. It means that the diabetic patient we need have a more attention, more careful, pay more attention to before decide to do the cataract surgery. In my opinion and also in my experience, I think that we must have a good control the TR before we decide to do the cataract surgeries. And now we have some many model treatment for the diabetic patients, and so that's I think that this may be before the areas of the anti-VEGF therapy. That's why the results make some confused about when we do the cataract surgery in the diabetic patients. But now we can do the cataract surgery more easier if we have a good control, and also we have some preparation before the surgery, like some fibrinolysis. It means that the drug for the anti-lipidemia in the diabetic patient, and also the progression of the diabetic patient. And also we have some anti-VEGF before the surgery. If we have, the patient has some sign or some symptom of the moderate diabetic retinopathy. And first of all, we have some many model imaging machine which can help us to find out and to decide exactly when we can do the cataract surgery. So that's why in my experience, I always do the cataract surgery for the moderate diabetic retinopathy. If the patient have a HbA1c lower than 8 millimole, and if the OCT show that is the normal of the macular, there is no, the technique is okay, no seed in the technique, and also in the funded color photo, there is no sign of the hemorrhage, the last hemorrhage or the neovascular. So that's why I can do the cataract surgery very confident. Thank you.
Thank you for that. So, is there any comment or questions about that? Here, Dr. Kung, please.
Thank you very much for your presentation. So I'd like to ask you that during the document you referred, are there any the data about the relations between the glucosamine level and the diabetic retinopathy after cataract? It means that after cataract surgery, glucosamine level of the patient higher than before, for example, or not? Because you didn't show in this presentation. And how about the times? The duration, maybe is that the duration from the surgery to the time the patient appear the diabetic retinopathy.
This, thank you for the question. This study have had a 6 year follow-up. Yes, 6 year follow-up. It's a long time than some previous study. Yes.
It's too long time to say that. I think it is too long time to say that there is a relation between the cataract surgery and the retinopathy, diabetic retinopathy. Because six years, there is many other factors to affect this disease.
And the result of this study, so after assisting some other sex or rich or duration, which is diabetes or level is HbA1c in blood. Yes.
So is there any comments? So I learned from your presentation and from Dr. Dat's presentation that we should pay attention when we do cataract surgery on the diabetic patients. We should explain to the patient that the disease may be progressive, or patient may see worse after the cataract surgery in the short term. Because diabetic retinopathy may progress, but more it progresses more rapidly than normal. So after 1 year or few months, patient may have a diabetic retinopathy. That's one thing. And the second thing, as Dr. Dat has said, we should pay attention on the HbA1c, that's the HbA1c level. And we should check if the patient have hemorrhage on retina or they have macular edema or not. So it means that we should do OCT, right? And if the patient have retinopathy, diabetic retinopathy already, we should we may inject the anti-VEGF before the cataract surgery. Is it right for that? To prevent the progression of the diabetic retinopathy. Yeah.
That's, may I have questions?
Yeah.
I have a question to Dr. Dat. So we have sometimes we have a patient with the patient have a diabetic, but doesn't have the retinopathy. So so do you think that we should use the multifocal for the patient? Because at the time we do surgery, the patient don't have the diabetic retinopathy, but in the future maybe it will appear. So.
Thank you. It is a very interesting question. Now, before the milestone study in the DME, the diabetic macular edema study, we know that there is a loss of the patient can lose the visual acuities in the after 10 or 20 years of the diabetic. So that's why they always afraid to do some multifocal lenses for the diabetic patient to prevent from the DME. But there is one protocol as this compared with the patient with the non-diabetic, the non-DME and the DME patients after the using the combined, it means that the cataract surgery plus with the anti-VEGF treatment for a long time. And there is no difference between the two group, and so that's they say that the vision is the same. So that's why we can do the multifocal lenses as for the normal patient. If before the surgery we check that there is no problem in the macula. Before in the natural cause of the DMEs, the visual acuity is the same group. So that's why we don't afraid that we can lose the patient, or we can have a trouble with the multifocal for the future in the futures. But we must check very carefully the macula before the surgery to sure that there is no DME before or combined with the cataract. So it means that I always do the OCT and always do magnification the macular area in the OCT to check to find out if there is any problem in the macula or not before the surgery.
Thank you. So, is there any question? I'm sure that's enough for today. Thank you very much, Dr. Hua, for your presentation, and I look forward to meet you next time for another presentation. And now we would like to invite the last one, and that's an update on the latest technology in refractive surgery by Ancon Company. Please. Oh yes, it's perfect if you speak English.
Yeah, first of all, I would like to say thank you so much for professional from Abdong and both of the manager and all the surgeon giving